including Elaine Trepanier, Garnet Holsapple, myself, Amanda Huff, and Julia Allen. And also joining us today is our newest member of our team, and that is John Pettigrew. So if you have any questions during the webinar, we ask that you please add them to the chat. So let's get started. So today we're going to be covering recent staff updates, as well as the continued impact of COVID-19, updates and overview of both the AMHH and the BPHC programs, critical incident reporting, home and community-based services or HCBS settings, legal guardian information, recertification, and the CAP survey. So here is the contact information for the 4 staff, and we will be adding another staff member, that would be John Poole, to the team. So her information is not quite there yet, but we will get that out. But you will see Julia Allen, Garnet Holsapple, myself, I'm Amanda Huff, and then as well as Elaine Trepanier. That's how you can reach all of us.
So I am just going to talk a little bit about the continued impact of the COVID-19 pandemic on how it's relating to the HCBS. So as you all know, on January 31st of 2020, CMS declared a public health emergency, or the PHE, related to the outbreak of COVID-19, making certain temporary allowances available to states for the duration of the PHE. Among these, CMS temporarily disallowed activities that would result in the loss or reduction of Medicaid coverage. To this end, auto renewals of expiring Medicaid program packages, including AMHH and BPHC, were instituted. Just kind of where we're at right now, the current public health emergency is set to last until October 16th of 2022. However, we've been told that we should be receiving a notification 60 days prior to the end of the PHE. So we've not yet received one for October, so just keep that in mind that it will probably expand, but that's not a guarantee for the next round.
So next up is the Adult Mental Health Habilitation, or the AMHH updates and reviews. Next slide, please. So effective as of July 1st, 2022, the AMHH State Plan Amendment, or the SPA, allows for licensed clinicians to sign off on an AMHH application in addition to the HSPPs. However, this has yet not been updated in Dharma as of today, but that is in the works. Next slide. Regarding diagnosis, the AMHH diagnosis updates, we ask that you please monitor the AMHH webpage for any updates to the list of the eligible diagnoses, and they are anticipated to be there next month in October 2022. And so these the slides will be sent out in a few days, and all of these links will be on those slides, so as a reference point. Next slide. So we're just going to do a quick overview of what AMHH is, which is an HCBS program consisting of 8 supportive services designed to habilitate skills necessary to live in the community to the highest standard of living. All these services are automatically assigned in a package. So think of it as the packages, or the individual receives like a bucket of services. This is meant for adults living with SMI and or substance use disorders. It's focused on habilitating skills for those at high risk for institutionalization to remain integrated in the community. It provides services to support both the member and family or non-professional caretakers. It cannot be provided to clients receiving MRO services. It can be used in conjunction with BPHC. The package duration is 360 days. There is a prior authorization, or PA, available to request additional units, and service unit maximums are consistent across level of need. Looks like There's a question in the chat.
Oh,
Are we
I
gonna-
apologize.
That's all right.
Yep, so, yep, Tracy, that's exactly accurate. The licensed clinician can sign the attestation for AMHH. The assumption is that that licensed clinician is already staffed with the HSPP as well over time, and so that additional staffing doesn't necessarily have to happen. We could find the code update and send that along to you too. Would that be helpful? Well, I'll just send it out to you, Tracy. Sorry. Yep. Yep. Okay.
All right, next slide, please. So AMHH members are eligible, or the eligibility for potential members, it's adults living in or transitioning to an HCBS eligible setting, adults that have reached the maximum benefit from rehabilitative services, adults that need or want habilitation to continue their recovery and sustain and or improve their quality of life in the community, and adults at risk of deterioration and institutionalization without services. The eligible criteria includes individual must be enrolled in Medicaid. The individual is 19 years of age or older, has AMHH eligible primary mental health diagnosis, has an ANSA score of 3 or higher, as well as the individual must meet the needs-based criteria as outlined in the Indiana Administrative Code, or IAC. Next, please. So AMHH and MRO are mutually exclusive programs designed to address different populations with different needs. So MRO is rehabilitative or focuses on rehabilitation. So it's focused on regaining lost abilities, whereas AMHH is habilitative, and its focus is to attain and maintain those abilities necessary for community integrated living. AMHH is designed for individuals who, due to their developmental hindrances, either have not developed the skills necessary to live independently in the community or are at significant risk of deterioration and or institutionalization without supports. So AMHH is ideal for transitioning long-term consumers of rehabilitative services with little progress on goals to focus on maintenance of goals. Next, please. So here's a side-by-side comparison of AMHH versus the MRO services. So MRO refers to rehabilitation, restoring any pre-existing skills to previous levels. And under that is a list of services that are included in MRO. So things like intensive outpatient services, case management, therapy services, medication training and support. Whereas AMHH, like we said, is the focus there is habilitation. So acquiring and maintaining those daily skills, daily living skills. And so the services that are included under AMHH are adult day services, supported community engagement, care coordination, respite care, HCB habilitation and support, therapy and behavioral counseling, addiction counseling, and medication training and support. Next slide. And of course, for additional information regarding the application process for AMHH, the crisis planning guidelines and clinical documentation requirements, please reach out to the set for agency-specific training. Now I'm going to pass to Julia to start us off with the BPHC information.
So we'll just be going through any updates and kind of review the application and renewal process of the BPHC. So just generally, the BPHC is a home and community-based services program designed to support those at risk of institutionalization in managing and coordinating their primary healthcare and behavioral health needs. The BPHC is a single service care coordination, which supports clients whose mental health symptoms impede their ability to effectively and independently manage their physical health needs. to allow clients living with serious mental illness to receive care in the community integrated settings to a similar level as those not receiving HCBS. It is concerned with supporting clients and goal achievement to attain their maximum level of independence and community engagement. So the applicant must have a BPHC eligible diagnosis as their primary diagnosis to qualify for BPHC services. The following are requirements for describing the diagnosis in an application. The symptoms associated with the BPHC eligible primary diagnosis must be provided in list format, and the list should consist of symptoms experienced by the client that disrupt their ability to independently manage healthcare needs. Do not list any additional diagnoses, physical health needs, intellectual and developmental delays or disabilities, or any information that does not directly pertain to the symptomology of the primary diagnosis. It's important to remember that any additional information could constitute a violation of HIPAA standards. So this is just an example of the different ways that you can format the symptoms that your client experiences. Can be in any of these orders, does not matter which you choose. If you would like a list of the BPHC eligible diagnoses, you can follow the link below. And as Amanda mentioned earlier, all of these slides will be available to review at a later date, so you'll be able to access the link later on. Then once we get to the physical health issues, you'll need to provide any physical health issues faced by the client that they have difficulty managing on their own. So the reported physical health issues do not have to be formally diagnosed, but should be presently impacting them. Historical injuries or illnesses that result in present-day complications are eligible, but physical health issues or injuries which the client is fully recovered from and does not experience complications are not eligible. It is important to note that a lack of history of accessing healthcare is an allowable health condition. Did you see? Mm-hmm. And then effective October 1st, 2020, we require that you provide 3 dates of services that the client received BPHC care coordination services for during that period, with a brief description of the support provided. One of these 3 services can be the reapplication process, but if fewer than 3 services were provided, we ask that you provide an adequate rationale for the lack of engagement and that you provide a plan for increasing engagement over the next package period. This can be either an agency-wide plan or a client-specific plan. And it's important to note, we talked about the public health emergency earlier, but once that ends, chronic ongoing underutilization could result in denials once the public health emergency ends. And then the justification of needs section on the application. The justification narrative should link the symptoms associated with the primary diagnosis to the behaviors that impede the applicant's ability to manage their physical health needs on their own. The narrative should only include information necessary to provide to the set with insight into the challenges the client faces in managing their health care. Stuff like personal history, family details, descriptions of other services received, additional mental health diagnoses, or any other information not directly related to the symptoms or impeding behavior should not be included. And this is just an example of how to format those sentences. The example we provided is that Dorothy's symptoms of paranoia causes her not to trust healthcare providers and follow provider recommendations.
So the next section we're going to review is regarding the goals. So the goal or the goals in the IICP should describe a behavior modification achievement, improvement in health, etc. the client would like to work towards or accomplish over the course of the eligibility period. So the goal then should preferably be written in the client's own words, like as a quote. It should reflect the client's personal desires. It should link back to the identified physical and/or mental health needs, supports the client reaching their desired level of independence, and ideally can be measured against.
continue.
So examples would be, I would like to lose 30 pounds. I want to be able to walk to the store without using my inhaler. I want to have fewer panic attacks. These are just examples. So then the next step is identifying the objectives. So these are going to be the steps or the actions that the client is going to take in order to achieve their previously identified goal. So the objective should build upon the client's strengths, their preferences, and any existing natural supports if available. Objectives should not be passive in nature, such as the focus would be that client will do and not client will allow. The objectives are to be clearly linked to the goal listed in the IICP, personalized to the client, and of course must be measurable. So an example, taking that goal of I would like to lose 30 pounds, the objectives could be client will attend meetings with dietitian once a month to plan healthy meals. Client will walk to the mailbox once a day to increase physical activity. And the client will reduce soda intake from 3 cans a day to 1 can per day. Next, please. So then the next step is identifying those strategies and the eligible activities. So the BPHC is solely care coordination, and the activities in this part of the application, you identify how the activities will be utilized or how the care coordination will be utilized over the package period to support the client in achieving their identified goals and achieve their desired level of independence. And in this section, any sort of MRO service should not be included. So BPHC can include coordination of care within and across systems, includes the oversight of the entire case or the logistical support, linkage to services or providers, advocacy, education, physician consults, serving as a communication conduit between team members, notification of changes in any medication regimens and health status, and coaching for more effective communication with providers. And all this information is further detailed in the provider reference module available at the following link, which will be in the slides that will be sent out within the next few days. Next slide, please. And so service documentation requirements for BPHC include that when documenting the BPHC service, it must reflect the progress towards the goals from the member's IICP, must be provided within the eligibility period, has to document the duration of service, accurately and adequately describe the service rendered, be written and signed by the agency staff rendering the services, support coordination or management of identified health needs and services, identify member strengths being utilized, incorporate natural supports where they're available, and describe the services benefit to the client. And these are the items that when the set comes to your agency to perform the annual QA, these are the types of things that we are looking for within the service documentation. So next slide. So in documenting services that are performed on behalf of the client, the progress note must contain the list of the names of all the individuals or persons attending the session and each person's relationship to the member, must describe the benefit to the member, describe how the service assisted the member in reaching the IICP goal, and the strengths and progress should also be documented. Next slide. So BPHC itself is one service, and that is care coordination. And only service activities that fall under the scope of this program are defined in the final rule are billable for reimbursement. So these would be provision of medical services or treatments, including but not limited to weight checks, blood pressure screenings, and blood sugar checks. So these are things that are not allowable. individual, group, or family therapy services, any service not described or supported by the client's IICP, service provided simultaneously with another service of the same scope and nature, leisure or recreational activities, and then of course life skills, medication, and or activities of daily living or ADL training. Next slide. So then with the public health emergency, it does affect documentation. So in this case, we asked that documentation that you specify how the service was provided, whether that was via telehealth, face-to-face, or on behalf of the client. And then if you're completing documentation on an application via telehealth, please indicate on the attestation and the RSST in some way that verbal authorization or agreement was obtained and the date that it was obtained. And then ensure the corresponding progress note matches the documentation of how the service was provided and the date. So just everything, all those items, you know, the application, the attestation, RSST, and then the documentation for all that would need to contain the same information regarding how the service was being provided or where, and then who was present and the date. Next. So just a few reminders that the ANSA must be completed within 60 days of the submission of a BPHC application. What we're seeing that is that if both the BPHC application and the ANSA are completed on the same day, and if the BPHC application is submitted to DARMA first, then DARMA is not linking it to the date of the, DARMA is linking it to the date of the last ANSA, which is typically more than 60 days prior. So for example, if you're doing your reapplication and you submit your reapplication, but you also did your ANSA, but you haven't submitted your ANSA, and your ANSA gets submitted after that, then they're not linking. And where the SET is having to pend those applications for further clarification. And so we recommend, the SET's recommending that the ANSA is completed in DARMA before commencing the BPHC application. Next. So the next is we're going to pass off to Garnet for critical incident reporting.
Hello, everyone. Hope everyone's well this afternoon. All right, critical incident reporting. So as we all know, incidents will happen and critical incident reports are expected by DMHA. So critical incident reports are a means to show that there's proper documentation of incidents. They also decrease liability for providers. You can also use them as a mechanism to show patterns or ineffective practices. Both DMHA and you as the provider are held accountable by CMS for reporting. And but we don't really worry about what to report and when to report, because we have our state plan amendment or the SPA and the residential rule, which provides us with guidance, and you can always reach out to us when you have questions. So today we're going to take a look at some incident types, reporting compliance, and the quality assurance process that was put into place a few years back. So incident types. Incident types are rather self-explanatory. However, questions do arise, and so please don't hesitate to reach out to any member of the SET. Now, Julia Allen is going to be taking over for me. I will no longer be working on the SET. So feel free to reach out to her or any member of the SET if you do have questions. If something happens and it's a weekend or a holiday and we're unavailable and you're really not sure, or go ahead and just submit that incident report. We'd rather that it be documented and submitted than go undocumented and then it's something that did need to be submitted, and then you're not getting your timely credit for that. So please go ahead and submit it. When in doubt, fill it out and submit it. If it's something kind of wonky and we get it, we can always reach out to you and kind of talk it through. So as a part of the state plan amendment, there are certain performance measures DMHA reports to CMS, and these are reported quarterly to the Office of Medicaid Planning and Policy, or OMPP, with an accumulative report being submitted every 3 years. Those performance measures are the number and percent of provider agencies who have policies and procedures to prevent incidents of abuse and neglect, exploitation, number and percent of incident reports involving medication errors resolved according to policy, number and percent of incident reports involving seclusions and restraints resolved according to policy. The state identifies and addresses incident reports involving death, number and percent of incidents reported within required time frames. So we're going to look a little bit closer regarding medication errors. In the past, there's been some uncertainty around this incident type. And here we have the definition from the National Coordinating Council for Medication Error Reporting and Prevention. And I'm going to give you a few moments to read this definition to yourself. Okay, so when we look at this definition, some things that we see are, it's an error that's preventable. It really kind of starts with prescribing the medication all the way down to administration of the medication. So we see everything from labeling to packaging, those types of things. What we don't see is when a patient declines the medication. So when we think about a patient refusing a medication, just on its own merit there, that is not considered a medication error. However, if you have a patient that has refused a medication and a consequence of that could be an incident report. So if you have a patient who has refused to take their blood pressure medication for several days, and that's resulting in them being hospitalized or something of that nature, then you're going to run into something that's going to have to be submitted as an incident report. And then when we are submitting incident reports in regards to medication errors, some things you want to make sure that you're documenting are: how is the incident addressed, preventative measures to decrease the likelihood of the incident reoccurring, when the prescriber was contacted, and what instructions were given to address the medication error. Okay, and we're going to look at the reporting time frames. So DMHA reviews 100% of the incident reports that we receive to ensure the incident report is submitted within the required time frame. They're required reporting timeframes for the different home environments. So we have the residential settings, and those are within 24 hours. And we have the outpatient community settings or the client's home, and those are within 72 hours. Now, there are some exceptions. For example, if you become aware that your client has passed away, you may submit that CIR when you are made aware of that passing. And so as long as it's submitted within the time that you have become aware, we go ahead and give you credit for those. Or you may have a client who lives in their own home, and you may go to see that client and have found out that they were in the emergency room 3 or 4 days ago, as long as you're submitting that incident report when you're made aware of it, we go ahead and give you credit for this. For CIRs that are being submitted outside of those timeframes, you'll need to fill out the explanation section on the CIR as to why the report was late, because that is part of DMHA's quarterly reporting requirements to OMPP and CMS. So with that being said, let's look at the overall reporting compliance for the past 4 fiscal years. We all know that the goal is to reach 86%. And I wanted to go back to fiscal year 19, which was before DMHA began the compliance process that we have in place now. And that's actually started for BPHC on September 1st of 2019. And for AMHH was October 1st of 2019. So keep in mind, the numbers you're looking at here reflect totals for both BPHC and AMHH. And if we look, 2019, the total number of incident reports that was being submitted was only 167. And compared to 2022, we had 228. And fiscal year 21, we had 247. And we think about it, we were kind of in the mix of the pandemic at that point in time. We also were at 70% back in 2019. So let's see, right after fiscal year 2019 ended was when we put the new quality assurance practice into place, and we jumped up to 86%. So we just made it at 86% for fiscal year 20. And you have to realize part of fiscal year 20 was pandemic had hit. So, but we also raised the number of CIRs that we were submitting, 220. You guys did hit the 86%. That's great. Fiscal year 21, we're still in the pandemic. Increased again, the number of incident reports that were submitted and went up our whole percentage, 87. Fiscal year 22, the number of incident reports decreased. However, we hit 91%, which is excellent. So we continue to trend upwards with the compliance reporting. So that's excellent. Excellent work on your behalf. We're really excited to see that trend going up. And I would like to just take a few moments to hear from some of you on some of the things that you've done within your agencies or things that you've implemented to meet the increase in those submissions and that timeliness. If you're shy and don't want to talk, you can put it in the chat.
Hey, Garnet, there was, well, folks are thinking that what they want to put in the chat or come off mute with. Susan had a question in the chat that was, would an inpatient unit be considered residential in your analysis of when the report?
For this program? Or
Susan, do you mind providing clarification on your question? Generally, for HCBS, when someone goes to inpatient, you wouldn't be billing HCBS anymore, but you may still need to complete the incident report if they're still on programming.
right, if they're still in, yeah, if they're still in programming, you'd still complete the report, but they would no longer be in the BPHC or AMHH program. So you would fill out the incident report of whatever services they're receiving, and those would be directed to the appropriate person at DMHA. Yes, for inpatient services, correct. You would go ahead and fill out. Depending on what program they're in, there's different guidelines and timeframes for certain programs, but generally for residential across the board, it's going to be 44 hours. But if anyone wants to share some things that you've implemented within your agencies to increase submissions, or things that you've done to increase the timeliness of incident reporting, we'd love to hear some feedback. Nobody has anything to share. All right, I guess we'll move on then. But if you think of anything and you want to go ahead and stick it in the chat, please feel free to do so. So we're going to look now at the compliance process that we implemented back in 2019. And again, that was September 1st for BPHC, October 1st for AMHH. So each CMHC receives a report of compliance each quarter. Reports are provided 15 days from the end of the quarter. For us, that kind of translates into the 15th of the month. As we know, some quarters end on the 31st. If it's February, it could be the 20th, 29th. So generally, we try to have that information to you, or those reports to you, by the 15th of the month. And if there's any additional follow-up that needs to be done, we attach that to those quarterly reports that go out by email. And if you look on the right-hand side, you see how the quarters are broken down, either BPHC or AMHH. Okay, for the informal adjustments, after the first 90 days of non-compliant CIR review, verbal or email guidance to the provider in the primary contact or provider supervisor as deemed most appropriate by AQI staff. DMHA will provide data to show compliance issues, including incident date and staff member that submitted the CIR. And because we know emails can get deleted or get lost, sometimes in the emails, we make it easier, but we just go ahead and attach a separate document for you that's listed informal adjustment with that information on there, so you can have that separate document for your records. And then the educational letter. So after the second 90 days of non-compliant CIR review, a formal notice is sent via email with either a read receipt, including a request to respond confirming receipt, to the CEO in addition to the primary contact. And again, the same information that's on the informal adjustment regarding the CIRs that were late. And the educational letter will identify the next steps if a third 90-day non-compliance review occurs. And then you see over on the right, if after 2 quarters since the educational letter compliance falls between 86%, an informal adjustment will be issued again, so we don't keep going up the chain as far as you don't jump them to a cap, pretty much. Next would be a corrective action plan, and that would be after the third 90-day non-compliant CIR review. This is a formal notice written letter on FSSA letterhead. Actually, they're all on FSSA letterhead, requiring corrective action, and an accompanying corrective action plan are sent to the provider for response. They include the responsible party, time frame for completion, a way for DMHA to verify that the cap's been completed, prevent reoccurrence, and to be effective. And if after 2 quarters since the cap compliance falls below 86%, you go back to education letter again. And additional action steps could be mandatory retrainings, increased visits based on progress, increased requests for documentation. Staff members must be retrained before providing service going forward. And then graduated sanctions, decertification of specific staff members, referral to FSSA audit, program integrity. And like we said earlier, Julia Allen will be taking over critical incident reporting for BPHC and AMHH. I've moved on to a different program here, but if you have anything with inpatient critical incident reporting, I will still be doing those. I'm still around, so if they do run into questions, they can always reach out to me. It's been nice working with everyone.
Well, Garnet isn't going far. She's still at DMHA, so if you want to send her some love or connect with her, she's still available in that way. This is Elaine Pequenier, outpatient residential QI team lead. We're going to talk about and close this up with HCBS updates and review. Settings information, legal guardian information, CAP survey, nuts and bolts. But I did want to address before I dive in the question, Sandy, that you posed about the challenge with DFR and the DFR financially denying the Medicaid messaging that appears in Dharma, specifically. Okay, how's that? Can you all hear me now?
No, it's kind of worse.
I'm sorry. Hang on 1 second. I've never been accused of not being heard, so I'm really surprised. Okay, I just turned up my. Oh. Take two. Sorry, my earbuds were in and I did not have them on. I've done this before. How do I sound now? Besides dumb. Thanks. Thanks, team. All right. So yeah, thanks. The question about DFR and that error, I shouldn't call it an error message, but the denied message that appears in Dharma. So this primarily happens with initial applications. If this ever happens with a reapplication, please reach out to Amanda and Julia and Jonquil to help problem solve through that. I am mindful to not throw my sister agency, DFR, under the bus, but they disagree that this automatic denial appears. So we've talked to them about this several times, that when an initial application is sent over, that in Dharma, immediately the next day it says DFR denied for financial and eligibility. And what is actually happening during that time is that the individual is undergoing eligibility review with DFR. It just shows up with that automatic denial language in Dharma. So if you have specific questions about individuals, we have a very tiny glimpse into IADS, the system that DFR uses to determine eligibility. We can see just enough to be dangerous, but we can look up to see that and confirm that eligibility review is being undergone for someone. So please reach out, let us know what's going on. And I know that we always say that, but really for this, it will help us for making the case to DFR. Yeah, it does. Melissa's right. It does say that way for the entire determination period, which is pretty frustrating. So if you let us know and we can take a look and confirm that eligibility review is happening, and then we can also use these as cases and examples to DFR that this occurs. So we've printed out the BPHC log and taken it in. We've had a local supervisor, got several of the, okay, yeah, staff turnover, DFR.
I don't know what to say. We will continue to do our best to make DFR aware of how things appear for us in the Dharma system. But we've all done this rodeo long enough to know that we need case examples to go to that or to help resolve that. So yeah, notice I'm nominating Amanda and Julia and John Quold. Sorry, team. But they are really experts in navigating this, problem solving these. So, and can look those individual cases up. So, yeah, anything else on DFR hiccups before Sandy? I can give you plenty of case examples. All right, go ahead and pop those off to the team, and we'll take a look. Anything else before I move on? Anything else about DFR and application related? I'm gonna assume not. All right, let's get cracking on HCBS stuff. Settings stuff, settings information, and HCBS final rule, the settings criteria of POCO, non-POCO, non-CMHC. We're not going to dive into that information today. There is still the full training that we did April of last year that's focusing on settings information, and no changes have been made to HCBS final rule since then. So if you have questions about settings information, please review that training. If you have specific questions about your agencies and your settings, email me and we can talk about your unique case examples. No problem at all. So yeah, thank you. Next slide. All right, so legal guardian contact information. Many of you were on our webinar that we conducted to talk about the implementation of the CAPS survey. The CAPS is Consumer Assessment for Healthcare Provider and Systems survey that we're rolling out. And I'll talk a little bit more about that in a moment for those of you who aren't familiar or who just need a reminder. But during that process, it revealed to us that we request information on legal guardian for AMHH and BPHC applications, but we haven't ever really reinforced making sure that we're getting accurate information. And so we are going to move towards making sure that we have a good phone number for legal guardian. We know that email addresses maybe prefer not to be used or don't get used, but we do need to be able to reach a legal guardian if we need to. And so we are going to move towards, if we have in the past allowed the clinician's phone number to be used or something like that, and we just realize that that's not helpful and not practical. So if we see those applications come through and recognize the phone number as the clinician or agency's phone number, we will pen the application, ask for the true phone number to the legal guardian, just so that we can be able to reach them if we need to. So yeah, the CAP survey just sort of revealed this need to us. So just letting you all know that you may see that in the future on applications. Next slide. So ongoing quality assurance reviews. Some of you are already experiencing this update that we're implementing. Sorry, Garnet just made me laugh and got me distracted. I apologize. So some of you may be already experiencing this, this change in our process. What we found was from feedback from the community mental health centers is that, you know, DMHA delivered site visits and QA reviews that was at a level that was burdensome to CMHCs. And so with our reorganization and our team restructuring, we have been able to look at our systems for doing QA reviews and have updated it to do the HCBS review combined with the clinical review, which includes the CMHC component, the addiction service provider component, the CANS and ANSA assessment component, and the block grant contract language component. So what we will do, since HCBS, we're bound by CMS policies and things in the state plan amendment. We are using the HCBS schedule as the infrastructure for this and following that calendar rhythm and schedule, and then weaving in the clinical review into that HCBS structure. So what it will look like is that you will receive your notification in the same email, and there will be 2 zip files attached, one that outlines what is needed for the clinical review to be completed, and one that is outlines what is needed for the HCBS review to be completed. And then also the notification that the 2 teams will arrive together on the same day. And then the reporting and outcomes will arrive in the same email notification as well. So this is what we know. We know that it's going to be intensive and, you know, probably have a little bit of growing pains, but all with the intention of doing a one-off visit each year to give CMHCs time to implement changes in needs based on the outcomes, and just give agencies time to digest and not having to be responding to site visits so frequently. You know, while we've made some very intentional efforts to blend these processes, one thing to note that for the CMHCs who also have private mental health institutions attached, those we were not able to weave together at this point in time, not to say it wouldn't happen in the future. So those site visits will still be conducted separately. But otherwise, we're trying to come out and do a one and done. We also crosswalked our clinical review practices with certification and licensure and worked to remove any areas where there was duplication. So we're trying to minimize the amount of things and amount of policies and items that we're requesting from CMHCs. And if we already have that information housed with certain licensure, we'll get that information from that location. So big updates there. Again, like I said, we know it's going to be intensive, but hopefully more streamlined. Now, all of this is as a result of CMHC feedback that we needed to have a reduction in site visits. So, you know, we know that there's going to be growing pains on both sides of the fence for this. And so as we go, we continue to be open to feedback and guidance on what works and how to make this work best. So let's just stay collaborative and share with us what we need to know as we go. Next slide. HCBS recertification and a new data system. I may have to punt back to Garnet to talk a little bit more about the data system, but recertification, we certify the community mental health centers to provide AMHH and BPHC every 3 years. The CMHCs are up for that recertification. I just wanted to highlight here that you'll get some letters from me within the next week or two to complete the sort of recertification process by the end of the year. The new data system, this is really, it's so new. We're really just using this opportunity as like a pre-messaging. You'll get more information about this along the way and be invited to attend some trainings and things like that. But we're working with Salesforce to develop a system where incident reports, licensure, certification, data, and auditing is all in one spot, and that we will have a communication mechanism with providers that moves away from using email, and that we can have sort of this hub spot, and you can have all of your certification, licensure, incident review or incident reporting, and quality assurance review stuff in one spot. So that will roll out over time, and these things always take longer than originally planned, but I am understanding that the intention is to start with critical incident reporting around the time of the end of this year. So this is just very early messaging, and I actually forgot to mention it in the morning. So if you knew someone who came in the morning and they didn't get this message, and they have some questions about it, they can pop us an email. But yeah, this is like a beware, more information will come kind of thing. Next slide. All right, so very quickly going to go over the CAP survey stuff. just because it is ending up requiring a bit of collaboration with the community mental health center. So I just want to make more folks aware of the survey. The CAP survey is a CMS design survey, and that is the web address there if you wanted to go to the CMS webpage and take a look at the survey components in full and the criteria and questions and things like that. So just want to make that available to you. Next slide. So I just mentioned it was designed by CMS and is intended for use within HCBS. It does measure participant experience rather than satisfaction. Using the survey will help us be able to look at program evaluation and if or what changes we might want to make. It also allows us to look at other HCBS programming across the country. If other states have implemented the CAP survey, we can cross-compare our data. All phases of the survey implementation adhere to confidentiality and security requirements, as one might expect. Next slide. I mentioned it measures participant experience rather than satisfaction. There's a sort of an extended explanation on that if you're interested. Next slide. So a little bit about the survey. It will take 30 minutes or less to complete and will be done by phone. The topics that will be covered will be how individuals acquire needed services, their communication with their providers, their case management, choice of services, personal safety, and community inclusion and empowerment. Next slide. These are just some sample questions. Again, if you go to that CMS webpage, you can see all of the questions in full, and they can be tailored to behavioral health, and we have tailored our survey towards behavioral health to the maximum that we can. Next slide. So rolling this out in Indiana, we have been receiving technical assistance to prepare for the implementation over the past year from Lewin Group, Westat, and CMS. We are working with WISE, Wellbeing Informed by Science and Evidence in Indiana, to implement the survey. And I think most of you are familiar with WISE and their work. And then also the Indiana University Center for Survey Research will be actually conducting the telephone interviews. Next slide. So why are we doing it? We haven't actually thoroughly assessed the recipient experience since the commencement of programming in 2014. It will take place over several months. The pilot program is starting soon. The big rollout will start in October, and we are expecting outcomes being reported about this time next year. Every individual that is an AMHH or BPHC recipient, it will be attempted to be contacted, except for individuals in the non-CMHC setting types, because those are licensed assisted living in most cases, and individuals that have gone into any rehabilitative care temporarily, or individuals who are on your programming but you're no longer providing services because of the public health emergency. And I mentioned that the test pilot is starting soon. Next slide. So individuals will be sent a letter explaining the survey and notifying them that someone will be contacting them. Recipients are encouraged to respond on their own, but they can use a proxy respondent, which a proxy is defined as an unpaid family member, friend, or neighbor. And we will be seeking legal guardian permission prior to proceeding with interviewing an HCBS recipient that has a legal guardian. Next slide. So this is the first time DMHA has conducted a CAP survey. It's also the first time the HCBS CAP survey has been utilized in behavioral health care, even though it's intended for behavioral health. So given all that, we don't really know what to expect in terms of outcomes. We do plan to use it for program evaluation, but we don't yet know how we're going to roll out the outcomes. It may be a statewide presentation, or we may follow up with CMHCs individually. We just don't know what to expect to predict what we're going to do with the information when we have it. So we'll let you know as soon as we do. Next slide. This slide is, most of you have seen this, and I can send it out again. This was a flyer developed by our communications department to support your direct service staff in having the conversation with their HCBS recipients that the survey is happening and what it is. So it's just meant to be a tool to support that conversation. Next slide. And if you have questions for the research team, you can call the 1-800 number associated with the survey, as well as email them at csr@indiana.iu, or pardon me, indiana.edu. And then you can also send questions to me in the HCBS inbox. And then an overview of the survey is there at the CSR webpage, but we also have put some information on the DMHA webpage if you're interested too. And I think that's it. So I'm gonna go off mute and punt it back to my team.
All right, thank you, Elaine. At this time, if anyone has any questions for the team, please feel free to unmute and ask your questions, or you may enter those questions in the chat. We'll take a few minutes, see if anybody has any questions. I hope that in the throughout this presentation, those of you who've had questions, that we've been able to answer those for you.
Hi, can you hear me?
Yes, we can.
Okay, great. I just have a quick question on reporting for the ED visits. So that when someone has to go to the emergency department or takes themselves to the emergency department for a variety of reasons, you want a critical incident report on each of those times, even if you're really working with them to reduce their ED utilization, but they may use it out of habit or out of anxiety or something?
Yes.
Okay, thank you very much.
Well, thank you all for attending our annual webinar. The presentation slides will be emailed out to everyone who registered within the next few days. And also a recording of this presentation will also be posted to our website. I'd like to thank you once again for attending. And if there's no other questions, have a great rest of your day. And feel free to contact any one of us here at DMHA for any questions. We are more than happy to provide whatever support, answer any questions that we can for you. Thank you, everybody.
Thank you. Bye-bye.